Usually when you think about human pregnancy, you imagine this like beautifully coordinated natural process, like a perfectly choreographed biological symphony.
Right, something very harmonious.
Exactly. But biochemically speaking, it is really more like taking a perfectly fine car, pointing it up a steep 9-month-long mountain road, and just completely flooring the accelerator.
That is a great way to put it. You are suddenly asking the maternal metabolic engine to do things it was never really designed to do on a flat highway.
And for a lot of women, that metabolic engine simply starts to overheat, right? Because we tend to, romanticize pregnancy as just a time of building and growth.
Oh, absolutely. But fundamentally, it is a state of profound physiological stress on almost every single organ system.
Yeah, and reading through the textbook of diabetes and pregnancy for this deep dive, I was honestly floored by what happens when that stress actually breaks the system.
The epidemiological facts laid out in the text are really sobering.
They are kind of wild. Like, babies of women with unmanaged diabetes are nearly 5 times more likely to be stillborn.
Which is a staggering statistic on its own.
And they are almost 3 times more likely to die in the first 3 months of life. Plus, twice as many are born with major congenital malformations.
And we are talking about a rare anomaly here. The incidence of gestational diabetes is hovering right around 3 to 7% of all pregnant women in the U.S.
And it's rising, isn't it?
It is steadily rising, which means if you are a medical student, a healthcare professional, or really just someone fascinated by human biology, understanding this clinical area is absolutely critical.
So to truly grasp how we manage this, we kind of have to logically trace the whole journey. We have to start with the normal metabolic changes of pregnancy, look at the pathophysiology when things go wrong, and explore the profound effects on the developing fetus.
Right, and then finally look at the practical clinical management strategies.
Let's jump into that normal physiology first, because before we can treat the abnormal, we have to understand why on earth pregnancy naturally provokes a diabetic-like state. On the surface, it seems like a massive biological design flaw.
I mean, it really does seem counterintuitive to deliberately make a mother insulin resistant, but it is actually this brilliant evolutionary survival mechanism.
Because the baby needs the sugar, right?
Exactly. A physiological state of insulin resistance is absolutely required during a normal pregnancy. The placenta isn't just, a physical barrier or a nutrient filter.
It's essentially a massive endocrine organ.
Yes. The outer layer of the placenta pumps out a massive cascade of hormones. We are talking human placental lactogen, cortisol, prolactin, and progesterone.
And all those hormones enter the mother's bloodstream and basically intentionally interfere with her insulin receptors.
They do. So the mother's body is deliberately making her own cells deaf to insulin. She might have plenty of insulin floating around, but the placental hormones are blocking the signal at the cellular level.
Right. The key is nutrient shunting. By making the mother's muscle and fat cells resistant to insulin, they take up way less glucose from the blood.
Which leaves a massive surplus of circulating glucose in the maternal bloodstream. And that is then directed straight across the placenta to feed the developing fetus.
So the mother's body is effectively prioritizing the baby's energy needs over her own tissue uptake.
Exactly. But going back to your car in a mountain analogy, the mother's pancreas has to compensate for this. To force that glucose into her own cells despite the placental blockade, her beta cells, the ones that actually produce insulin, have to drastically increase their output.
The text notes they can increase insulin secretion up to 4-fold, which is incredible, but there is a huge hormonal tug-of-war happening behind the scenes, right?
Oh, absolutely. Estrogen actually promotes beta cell function. It helps them grow and secrete more insulin.
But it is constantly battling the profound insulin resistance caused by progesterone and human placental lactogen.
And that battle is the crux of the entire issue. Gestational diabetes mellitus, or GDM, occurs when the pancreas simply fails that stress test.
So a woman might have like a pre-existing beta cell defect or perhaps chronic underlying insulin resistance related to genetics or a higher BMI.
Right, and when she gets pregnant, she starts to climb up that mountain, already running at maximum RPMs. Her beta cells cannot physically produce enough insulin to overcome that tsunami of placental hormones.
And so the maternal blood sugar spikes and maternal hyperglycemia ensues. Her pancreas fails and her blood is suddenly flooded with excess glucose.
But that sugar has to go somewhere. And unfortunately, the placenta acts like an open floodgate for it, pouring it directly into the fetus.
Which brings us to a massive concept in the text, the Peterson hypothesis. And this is where I want to push back a little or ask a question. If the mother has high blood sugar, does the baby just absorb all that extra energy and get, like, really healthy and well fed? I mean, why is a big baby actually a medical emergency?
That is the pivotal question. The Peterson hypothesis explains the specific mechanics of placental transfer, and it is a foundational principle in understanding diabetic pregnancies.
Because the placenta has very strict rules.
It does. Glucose moves across via facilitated diffusion. It is entirely concentration dependent.
So if the maternal sugar is high, the fetal sugar is automatically high.
Precisely. But maternal insulin does not cross the placenta. It is simply too large of a molecule.
Wow, okay. Which means the fetal pancreas suddenly has to wake up and handle this massive sugar load all on its own. The baby is flooded with maternal glucose, but gets absolutely none of the maternal insulin needed to process it.
Exactly. So the fetal beta cells start working in overdrive, churning out massive amounts of insulin. And this is where the real danger starts, because insulin isn't just a metabolic regulator.
For a fetus, insulin acts as a primary growth factor.
Right. It functions like a highly potent biological fertilizer. This constant state of fetal hyperinsulinemia leads to excessive abnormal growth. Clinically, we call this macrosomia.
Which is typically defined as a birth weight over 4,000 grams, right? So roughly 8 pounds, 13 ounces.
Yes. But the thing is, macrosomia isn't just a chubby, healthy baby. The growth is heavily disproportionate.
Because the excess glucose is stored as fat and glycogen, particularly around the fetal abdomen and shoulders.
And it leads to organomegaly, which is the abnormal enlargement of organs like the heart and the liver.
And that disproportionate growth sets the stage for severe physical trauma during birth. I mean, if the baby's abdominal circumference and shoulders grow significantly larger than their head, you run into the terrifying scenario of shoulder dystocia.
Which is an absolute nightmare scenario.
Where the baby's head is delivered, but
Yeah.
their shoulders literally get physically stuck behind the mother's pelvic bone.
That is a true obstetric emergency. But the danger of that hyperinsulinemia doesn't actually stop once the baby is finally delivered.
Right, because think about the mechanics of delivery. The moment the baby is born, the umbilical cord is clamped and cut.
And in a split second, the maternal sugar supply drops to absolute zero.
But the baby's pancreas doesn't know the buffet is closed. The newborn's bloodstream is still saturated with astronomical levels of insulin from dealing with the mother's glucose.
So you have a massive amount of circulating insulin with suddenly no glucose to process. This drives whatever glucose is left in the newborn's blood straight into their tissues.
Causing the newborn's blood sugar to just absolutely plummet.
And this severe neonatal hypoglycemia can cause seizures, brain damage, and it requires immediate intervention in the neonatal intensive care unit with intravenous glucose.
The long-term consequences detailed in the text also blew my mind. We are talking about metabolic imprinting.
Yes, this is a fascinating area of research.
Exposing a developing fetus to a high-sugar, high-insulin intrauterine environment permanently alters the architecture of their own pancreas and metabolic pathways.
It physically imprints on their developing systems. These macrosomic babies have a significantly higher statistical risk of developing obesity, metabolic syndrome, and type 2 diabetes themselves later in life.
It creates this vicious generational cycle where diabetes literally begets diabetes.
Which is why capturing this early is so important. Because the timing of that sugar flood dictates the specific type of damage to the fetus. Catching the spike early is everything.
And this requires us to draw a very strict line between a woman who develops gestational diabetes during pregnancy and a woman who had pre-existing type 1 or type 2 diabetes before she conceived.
The distinction really comes down to embryology. During the first trimester, roughly weeks 3 through 8, the fetus goes through organogenesis.
This is when they are basically building the house, the neural tube is closing, the heart chambers are forming, the skeletal system is taking shape.
And high blood sugar during organogenesis is highly teratogenic. Teratogenic meaning it directly causes physical malformations or birth defects.
Because the hyperglycemia creates severe oxidative stress, right?
Yes, oxidative stress that disrupts the exact cellular signaling required for those organs to form correctly. This is why major congenital malformations, like transposition of the great arteries in the heart or neural tube defects in the spine, are vastly higher in pregestational diabetes.
Whereas in gestational diabetes, the insulin resistance doesn't usually peak until the late second or early third trimester.
Driven by that late surge in placental hormones, exactly. By that point, the house is already built. The organs are fully formed.
So the excess sugar just causes the house to expand rapidly, which is why the primary risk in GDM is the macrosomic growth we just discussed, rather than structural birth defects.
And this timing dictates our entire screening protocol. Standard screening for GDM happens at 4 to 28 weeks, capturing that peak hormonal surge. But the screening protocols themselves are a major point of debate in the medical community.
Yeah, reading that really made me think of airport security. When you were trying to catch a threat, do you screen every single passenger who walks through the door, like universal screening?
Right.
Or do you only pull aside the people who fit a specific risk profile? Like if a patient has a family history of diabetes or higher BMI, they get screened. But if we only use risk profiles, aren't we bound to let dangerous, asymptomatic cases slip right through the cracks?
The data in the text strongly supports that exact concern. Relying purely on risk-based screening, meaning only testing those with obvious clinical risk factors, misses a significant portion of GDM cases.
Some studies cited in the text suggest risk-based screening can miss almost half of all cases.
Half of all cases. This is why universal screening, typically using a 50-gram oral glucose challenge test, where the patient drinks a glucose solution and has their blood drawn an hour later, is increasingly the standard of care.
Furthermore, for those high-risk populations, waiting until 24 weeks is just too late. Screening at 16 weeks is strongly recommended to catch early-onset glucose intolerance.
And for those women with pre-existing type 1 or type 2 diabetes, the practical takeaway is the absolute necessity of preconception care. If high sugar in the first 8 weeks causes birth defects, a patient needs to have their blood sugar strictly normalized before they even stop using contraception.
The text emphasizes getting a patient's HbA1c as close to normal as possible. And just to clarify for everyone listening, HbA1c is essentially a 3-month historical average of your blood sugar, measured by looking at how much glucose has permanently stuck to your red blood cells over their lifespan.
Normalizing that HbA1c preconception is the single most effective intervention to prevent those congenital malformations. The preconception period is also when you absolutely must manage pharmacology.
Right, like with blood pressure meds.
Exactly. For instance, ACE inhibitors are incredibly common blood pressure medications used to protect the kidneys in diabetic nephropathy. But they are strictly contraindicated during pregnancy because they restrict fetal renal blood flow.
And that can cause severe fetal kidney damage. So they must be transitioned to pregnancy-safe antihypertensives before conception.
So armed with the pathophysiology and the diagnosis, you have a patient sitting in your clinic. How do you actually manage this to prevent the macrosomia or the neonatal hypoglycemia?
Right.
When the pancreatic stress test fails, how do we fix it?
Well, the absolute cornerstone of management is medical nutritional therapy, or MNT. But pregnancy requires a very delicate balancing act.
The goal is euglycemia, perfectly normal blood sugar levels, but without pushing the mother into ketosis.
Ketosis being the state where the body, starved of carbohydrates, switches to burning fat for fuel. That fat burning produces ketones. And while a keto diet might be popular for weight loss, in pregnancy, those ketones cross the placenta and can be highly neurotoxic to the developing fetal brain.
Which is so important to note. So you can't just tell a pregnant diabetic patient to eat 0 carbs. You have to provide enough daily calories and complex carbohydrates to support healthy fetal development while aggressively blunting the massive post-meal glucose spikes.
And the text provides highly practical tools for dietary counseling here. It's not about generic calorie counting. It is about identifying the specific carbohydrates that break down into simple sugars the fastest. We focus heavily on the big 5 carbohydrates.
The big 5 being potatoes, rice, pasta, bread or tortillas, and cereal. If a patient can master strict portion control of these 5 specific foods, they are incredibly likely to achieve their glycemic goals.
And the reason we target these 5 isn't arbitrary. It all comes down to the pharmacokinetics of digestion.
Digestion speed is everything.
Right, like if you eat a cup of broccoli, the heavy fiber means your digestive tract takes hours to break it down, resulting in a slow, gentle trickle of glucose into the bloodstream.
But if you eat a baked potato,
Salivary amylase starts breaking that down right in your mouth. By the time it hits your stomach and small intestine, enzymes cleave that starch into pure glucose almost instantly. It floods the portal vein, hits the maternal bloodstream, and within 45 to 60 minutes, it is at maximum concentration hitting the placenta.
which perfectly explains the most critical paradigm shift in glucose monitoring. To know if medical nutritional therapy is working, the patient has to test their blood sugar at home.
Historically, the medical field focused heavily on fasting sugars. having the patient test right when they wake up, or preprandial sugars right before a meal. But the data now overwhelmingly dictates that 1 hour postprandial monitoring testing exactly 1 hour after finishing a meal is vastly superior.
And that ties right back to that digestion speed. The 1 hour mark captures the absolute peak glucose surge that the fetus is exposed to.
If you wait 2 hours to test, the maternal sugar might look normal again. But that giant spike of glucose has already crossed the placenta, the fetal pancreas has already panicked, and the fertilizer has already been applied.
Exactly. Treating to lower that specific 1 hour postprandial peak gives you real-time actionable feedback on how a specific meal impacted the system. The text demonstrates that targeting the 1 hour mark is significantly better at predicting lower overall daily insulin needs.
And successfully preventing macrosomia and ultimately reducing the rates of cesarean sections. But what if medical nutritional therapy just isn't enough?
That is the next step.
Like, what if a patient is meticulously portioning their big five carbs, they are testing exactly 1 hour after meals, but their blood sugar is still persistently high?
When diet and exercise fail to maintain euglycemia, we must escalate to pharmacology. Historically, and still considered the gold standard in many high-risk scenarios, is insulin therapy.
Since maternal insulin does not cross the placenta, injecting exogenous insulin directly lowers the mother's blood sugar without exposing the fetus to the drug itself.
You can titrate the dose exactly to the patient's changing needs as the placental hormones increase throughout the pregnancy.
The problem, though, is compliance. Asking a pregnant woman to take multiple daily subcutaneous injections of insulin on top of finger stick testing her blood sugar 4 times a day is a massive psychological and physical burden.
It really is. Which is why the text discussion on oral anti-diabetic agents is so interesting and relevant. There is robust emerging evidence for oral agents, specifically a drug called glyburide.
Glyburide belongs to a class of drugs called sulfonylureas, right?
Yes. And instead of acting as an insulin replacement, it physically binds to receptors on the mother's pancreatic beta cells, essentially forcing them to squeeze out more of her own endogenous insulin.
And the crucial part here is the placental transfer.
Precisely. Extensive studies have shown that glyburide binds so tightly to maternal plasma proteins that very little of the active drug actually crosses the placenta.
This significantly mitigates the fear of fetal teratogenicity, or directly causing fetal hyperinsulinemia. It offers a highly efficacious, patient-friendly alternative to injections.
For many patients, popping a pill is far more manageable, and the clinical outcomes in terms of maternal glucose control and neonatal health are highly comparable to insulin therapy.
We have covered a tremendous amount of physiological ground from the textbook of diabetes and pregnancy today. Let's rapid-fire recap the journey.
Good idea. We established the baseline physiological requirement of pregnancy. The placenta acts as an endocrine organ, pumping out human placental lactogen and progesterone. This creates profound maternal insulin resistance to shunt glucose to the baby.
And gestational diabetes occurs when the maternal pancreas cannot increase insulin output enough to overcome this resistance.
Then we explored the Peterson hypothesis. The mother's excess glucose freely crosses the placenta, but her insulin doesn't.
So the baby's pancreas responds by creating a state of hyperinsulinemia. Because insulin acts as a potent growth factor, this leads to macrosomia, disproportionate growth, the risk of shoulder dystocia, and severe neonatal hypoglycemia the moment the umbilical cord is severed.
We also do the vital clinical distinction based on the timing of the hyperglycemia. Pregestational diabetes strikes during the first trimester period of organogenesis, carrying a high teratogenic risk of severe congenital malformations,
which mandates strict preconception HbA1c control. GDM strikes later, primarily affecting fetal growth rather than structural formation.
And finally, we detail the management strategies. We discuss the necessity of medical nutritional therapy, focusing heavily on avoiding ketosis while strictly portioning the big 5 carbohydrates.
We established the clinical superiority of 1 hour postprandial glucose monitoring to catch the digestion peak. And we explored the transition to pharmacology, utilizing either insulin or oral agents like glyburide to keep the maternal blood sugar normalized.
To cement what we've covered, we want to challenge you, the listener, with a short clinical review exercise.
All right, here is your scenario. Imagine you were managing a 26-week pregnant patient who was just newly diagnosed with gestational diabetes. She is sitting in your clinic, and she wants to know exactly when she should test her blood sugar tomorrow and what specific food group she needs to watch most carefully at dinner. Based on today's deep dive, what is your evidence-based recommendation?
Take a second to think about the physiological timing we discussed.
Got it. You are going to tell her to test her blood sugar exactly 1 hour postprandial, 1 hour after she finishes her meal.
You tell her this because that captures the peak glucose surge hitting the placenta, making it the most accurate predictor for preventing fetal macrosomia.
And at dinner, she needs to practice strict portion control of the big five carbohydrates: potatoes, rice, pasta, bread or tortillas, and cereal.
If you understand the why behind those two simple interventions, you are already equipped to drastically improve clinical outcomes for these patients.
As we close out, I want to leave you with a final provocative thought. We spent a lot of time today talking about managing a single pregnancy.
We did.
But if we look back at the concept of metabolic imprinting, the idea that exposing a fetus to high sugar permanently alters their own pancreatic architecture,
Wow.
creating a cycle where diabetes begets diabetes.
It changes the scope of our work entirely. Aggressively treating a single pregnant woman today isn't just about ensuring a safe delivery for one infant.
Right.
It is actually intercepting a chronic disease process at its biological genesis. By normalizing that intrauterine environment today, we are actively preventing the metabolic imprinting that predisposes that unborn child to diabetes decades later.
Which means treating gestational diabetes isn't just a niche obstetric issue. It might actually be our single most powerful medical weapon for eradicating the global epidemic of type 2 diabetes in the generations to come.
You aren't just managing one patient, you are literally redesigning the metabolic health of the entire human fleet that follows.
Something to chew on the next time you are studying the endocrine system or see a GDM patient on your schedule. Thanks for taking this deep dive with us.